what do you usually mean when you pronounce dementia, when you talk about dementia? Could you please tell about these different diseases that are grouped under the name concept dementia?
So the term dementia is very broad. And what it essentially means is that an individual has had a decline of their mental faculties, or cognitive functioning, we call it. From a certain level, they're going down to the point when they can no longer look after themselves. They cannot live independently in the community. So that is really broadly the definition of dementia. So the first thing that comes up, of course, is that we try to distinguish it from normal aging. We know that there are some changes that occur as people get older in terms of some cognitive function. So when we look at cognitive function, we look at various faculties. We look at memory, learning and memory. That's one which commonly people talk about cognition, they talk about memory. But we also talk about executive function. That is a higher mental function which makes us help plan, organize, look at abstractions, abstract things as opposed to concrete aspects of reality. Then we look at language function, ability to navigate oneself in the environment. That's a visual spatial function. And there are other cognitive functions that we look at as well. And we find that as people age, one thing that happens is that we slow down in our reactions. Our reaction times go up. We call it processing speed. The speed at which brain does function. We know young people do act very quickly, respond very quickly. But even from your early 30s, you actually start slowing. And that continues.
My point of life, yes.
Yeah, absolutely, yeah. But it doesn't mean that older people can still perform the task, but they take longer to do the task. That's one thing. The other thing that do find some degree of change in executive function, that also happens through life. But then when you actually track people later in life, say after the age of 60, and especially after 70, you find that there is a drop in many other functions as well. For example, memory goes down to some extent, but not hugely. And there are some functions that are preserved, like vocabulary is one thing that is preserved. Moral reasoning, there are some certain aspects of that kind of well preserved in older people. But still, older people, even though there is some decline, they function adequately in society. They can do all the activities. They can function in high-level jobs. Often they have skills by which they can navigate those. But what happens if dementia sets in? Often dementia doesn't come in overnight, especially most of the common causes of dementia. There are rare cause or uncommon causes of dementia that happen over short periods of time as well. Because dementia is a broad term and there are several causes. In fact, look at a textbook on neurology, there are over 100 causes of dementia. But there are some causes that are common. And like you heard of Alzheimer's disease, vascular dementia, dementia with Lewy bodies, frontotemporal dementia, and late is another newly formed. These are the more common forms of what we call neurodegenerative dementias.
What is late? It's the first time when I hear it.
I'll come to that, I think maybe a bit later. Yeah. But the point I want to make initially was that dementia doesn't happen overnight. It takes a long time. And now we know that often the abnormality in the brain that causes dementia eventually starts 20 to 30 years before you present to the clinic with symptoms of dementia. So often in your 50s, early 50s, even earlier perhaps, that this pathology, and gradually it accumulates over time, and to a point that it starts compromising your function. Because there is a reserve capacity in the brain. Even if you have pathology, brain can function.
I saw the studies where people hypothesized that in men, the onset of dementia, but in an implicit way, starts around 35, 40 years old. And for women, the start is later, but the progression is much faster. Is it true?
I'm not sure whether we have good data to support it. I think this is one area which has been a bit fraught about sex differences. Much of the literature seems to suggest that dementia is more common. There are more women with dementia, I should perhaps say that. But of course, there are more older women, because women live longer than men in most societies. In Australia, I think it's for 4 years difference in life expectancy between a man and a woman at birth.
So not all men can live as long as to have dementia. Yeah.
Yeah. So no, because there'll be more women in the 80s and 90s. So there'll be more people, more women with dementia. So that is one reason that there are more women. Yeah. So that is what we term prevalence in epidemiology, when you look at the total number of people with a particular disease. But the other thing we want to look at is incidence. So if you compare people, say between the ages of 60 and 70 or 70 and 80, and say how many will develop dementia in this year, in 2026, new cases. Then you're accounting for age differences, you're accounting for survival differences, and then you can compare apples with apples in a way, whether that is. And I think we don't have very good data to suggest that women have a higher incidence. I mean, some of our studies suggest that may not be the case. There have been a couple of studies. There was a Taiwanese study, and there was a Canadian study which showed that the incidence was slightly higher in women relative to men. But as far as rate of progression is concerned, I'm not aware of any good data to suggest that the rate of progression is greater in women as opposed to. Yeah.
But sticking to the point of normal aging and dementia, there is something which sits in between, which is mild cognitive impairment. Can you tell us a bit more about mild cognitive impairment and where does it land?
So if you say just accept that dementia is developing over a long period of time, so what happens is that, of course, once the brain's reserve capacities give in, have been overwhelmed, the person starts developing mild symptoms, but they're still able to function. So this may be, say, a person who's even a high-functioning person, executive, who's running a company or something. He starts delegating more to his secretary or hires somebody else to manage certain things. Someone else is managing his emails. So he's basically trying to deal with his cognitive impairment by using various strategies. But he still has problems. He may have excuses sometimes that, okay, I just forgot, or maybe I'll come back to it later. He's in a position to do that. So that kind of person may be someone we call mild cognitive impairment. So basically they have cognitive impairment. If you test them, there is good evidence that they have declined. They are functioning in a somewhat impaired range, but they can still do the activities of daily living with some effort or with some help and still function independently in society. But when that reaches a point when that compensation is no longer possible, then we say that the person now is demented. So it's a kind of a difficult threshold to determine sometimes. And often the context as well, really, as to when you call it dementia. And there could be debate sometimes. If you're at the threshold, one doctor may call it MCI, or mild cognitive impairment. The other one may call it dementia. So it's a kind of a rubbery thing. And that's why I think more and more now there is a push towards defining these disorders by the pathology rather than just the symptomatology. For example, Alzheimer's disease, that has progressed the greatest, where now, at least in research, what we do is we look at the pathology, state of pathology, and then say, okay, look at the symptoms, and then try to relate the two. But we say, okay, this person may have pathology, may not have symptoms, or may have severe symptoms. And sometimes the two don't always correlate very well. At least some pathologies don't always correlate with the symptoms. And that is because the presentation of symptoms is determined by many factors. Pathology is just one of them.
So the presence of amyloid plaques is not a necessary condition to develop Alzheimer's disease, right?
No, it is.
I mean, symptomatically.
So we do recognize Alzheimer's disease by the presence of amyloid plaques and neurofibrillary tangles. So that's a requirement for the diagnosis. Of course, but in clinical practice, we don't always look for them. Because we can do PET imaging these days, and we can do blood, CSF and blood biomarkers to actually look for these pathology in these. But we don't always do that. We sometimes just go by the clinical picture to do. But what I must say is that the presence of amyloid in the brain doesn't mean that the person has dementia or even MCI. You have amyloid in the brain and still function normally.
Wow.
In fact, if you look at people in the 70s and 80s, many studies have shown that you do amyloid imaging on them using PET scanning. You find that 25 to 30% of them have amyloid in their brains. These are people who are otherwise functioning normally. They're not coming to a doctor with cognitive complaints.
Dear researchers, I think this is a very nice example to start the new branch of studies of Alzheimer's disease with this type of patients. Their brains somehow managed how to restrain Alzheimer's disease.
Yeah, so that's a good point. Of course, we do know that people with amyloid in their brain are more likely to progress if you follow them over 5 years, 10 years, than people who do not have amyloid. So they have the vulnerability. The pathology is building, and but one possibility is that they need more than amyloid to develop. And we think that development of tau pathology, the neurofibrillary tangles that develop, that they're the ones we think are relate better to cognitive decline, to symptomatology. And then there are other aspects, other things that are happening in the brain as well. There is inflammation that is happening as well, and neuronal loss is happening, network loss is happening. So those relate better to the presence of symptoms rather than just the amyloid. Now, there's some people, many people in the field who believe that amyloid may be the basis initially that sets up the whole pathology, and that kind of transmutes into the other pathologies later. And that is called the amyloid hypothesis. Although not everyone accepts that hypothesis. Some people believe that that's not insufficient to explain Alzheimer's disease, and then there are other pathways to developing Alzheimer's disease.